Hello, my name is James Song. I'm a dermatologist at Frontier Dermatology based in Mill Creek, Washington, and I welcome you to another IPC Take 10 segment where today we'll be discussing what is new and up and coming with our psoriasis therapies. These are my disclosures. So earlier this year, Dr. Andy Blauvelt presented his preliminary results from his phase 2 knockout study, and he was able to show fairly convincingly that if we use higher doses of risankizumab, so 300 or 600 milligrams sub-Q, not only is it safe, but it can lead to even higher levels of efficacy, and in certain individuals, even put them into a state of remission. So if you look all the way to the right, these were the PASI 100 responder rates from the study. At 22 weeks, we're seeing over 80% of patients getting to 100% clear. And at 52 weeks, where patients have stopped therapy now for 9 months, still over 40% of patients were 100% clear. And so these results are very exciting, but it also paved the way for the first treatment that we're going to talk about, which is Oruka-001. This is a novel extended half-life monoclonal antibody that had a similar epitope to risankizumab, but thanks to this YTE technology, it actually has a half-life that is anywhere from 3 to 4 times greater than risankizumab, as demonstrated by this non-human primate study here on the top right-hand corner. So with higher efficacy and a potentially better dosing regimen where patients only need to receive the medication once to twice a year, then this could be a clear advantage than what we currently have with our IL-23 inhibitors. And next, I want to talk about nanobodies and antibody mimetics. So our current monoclonal antibodies are complex ordinary structures made up of two heavy and two light chains. But the problem is that these are very large, they are difficult to manufacture, and they are relatively unstable. But it turns out that if you use a camel rather than a Chinese hamster ovary to make your antibody, you get two distinct populations. You still get your typical monoclonal antibodies that are made up of the two heavy and light chains, but you also get this distinct population of what we call nanobodies. So they're made up just of the variable heavy domain of the heavy chain. They don't actually have a light chain. So they're actually 1/10 the size of a traditional monoclonal antibody, and the potential advantages of a nanobody is that they have better tissue penetration, improved stability, and they are cheaper to manufacture. So sonelokimab is a trivalent camillidine nanobody that is currently under study for psoriasis, HS, and psoriatic arthritis. And you can see it has three distinct moieties. The N moiety binds to IL-17F, the C moiety binds to either A or F, and then the central moiety binds to albumin, which extends its half-life up to 12 hours. And so this is a therapy that should be coming to a theater near you. Next is izokibep. This is an alpha-body small protein therapeutic, not technically a nanobody, but still has a lot of the same advantages, being 1/10 of the size, a better tissue penetration. It blocks IL-17A, but with higher affinity than ixekizumab and secukinumab, and that is thanks in part due to these co-simultaneous IL-17A binding domains. And you can see that this is currently under study for PSA and HS as well. And lastly, I want to talk about oral therapies because this is really where the innovation is going because patients still have a strong preference for medications that you can take orally. So the first one I want to talk about is Orismilast. This is a next generation PDE4 inhibitor. We know that PDE4 is overexpressed in immune and non-immune cells in various different inflammatory skin disorders, but it's PDE4B and D that are the predominant subtypes that are overexpressed. And when you look at the IC50 values for Orismilast and you compare it to apremilast, you can see that for the PDE4B and D subtypes, Orismilast is anywhere from 2 to 40-fold greater than apremilast. But does that actually translate to better efficacy? This is your phase 2 dose ranging study for Orismilast. And if you look at the highest dose, which is 40 milligrams BID, at the PASI 90, about 25% of patients are getting there. And if you compare that to apremilast from their phase 3 study or oral roflumilast, we are seeing more than twice the efficacy with Orismilast as our current PDE4 inhibitor. So we clearly are seeing an improvement there. From a safety and tolerability standpoint, though, so not a surprise, we're seeing a lot more gastrointestinal disorders with Orismilast, and this is one of the most common reasons patients dropped out of the study. So this is still an area that we have to improve on. And next, deucravacitinib. This is an oral allosteric selective TYK2 inhibitor. These are your PASI 75 responder rates from the pivotal studies, and you're seeing that clearly at 16 weeks, deucravacitinib is superior to apremilast, but this continues to get better over time. So 24 weeks is where this drug hits its peak efficacy. Now, when you compare that to zasocitinib, which is formerly known as TAK-279, which is a second generation TYK2 inhibitor, and this was actually developed by artificial intelligence. Thanks to a single amino acid difference, you're seeing a binding selectivity that's about 1 million-fold greater for TYK2 than JAK1 at the JH2 domain. And when you compare that to deucravacitinib, it's about 10,000-fold more selective. Now, on the right-hand side, we are looking at the concentration of zasocitinib and deucravacitinib at the IC50 threshold for various different cytokines that signal through TYK2. And if you look at that blue dotted line, that's the IC50 for IL-23. And with zasocitinib 30 milligrams once a day, you are seeing that it is well below or well above that threshold for the entirety of the day, for 24 hours above the IC50. Whereas with deucravacitinib, it's only above that threshold for about 3 hours before it drops below. So when you look at the phase 2 data for zasocitinib, we're seeing over 40% of patients at the highest dose getting to a PASI 90, right? And that is only at 12 weeks. So we're seeing clearly that this drug seems to work faster than deucravacitinib and with potentially even a greater depth of response. And from a safety standpoint, overall, very reassuring. We are seeing a little bit more acne, which is more of a class effect with this medication. ESK-001 is the other TYK2 inhibitor, also a highly selective allosteric TYK2 inhibitor. And I want to draw your attention to this table down here on below. I highlighted the IC90. So that is essentially complete inhibition of TYK2. And if you look at the 40 milligram BID dosing, okay, ESK-001 is able to be above that IC90 threshold for greater than 24 hours. And that's even more so than zasocitinib, which is only 5 hours over that IC90. And with deucravacitinib, we're not getting there at all. So to just kind of summarize, to achieve maximal efficacy, 24 hours of TYK2 inhibition is required, and we could potentially get there with a 40 milligram BID dosing of ESK-001. When you look at the phase 2 results for ESK-001, we are seeing numbers that are fairly comparable to what we saw with zasocitinib, just a touch under 40% getting to PASI 90, and this is at 12 weeks. So again, this seems to work more quickly than deucravacitinib, and from a safety standpoint, again, very similar. We're just seeing a little bit more acne and folliculitis. But last and not least, I want to talk about a J&J 2113. This is the first and only macrocyclic peptide that we have in dermatology. And macrocyclic peptides have often been referred to as the Goldilocks because they're not too large, which would require an injection. They're not too small, which struggle with complex protein-protein interactions. But due to this unique kind of cyclic ring structure, it allows it to cover large, extensive areas, and it could effectively disrupt protein interactions that are important for various diseases like psoriasis. So you can see that this peptide is intermediate in size between a small molecule and an antibody. This is an IL-23 receptor peptide antagonist, very potent. So you just need a little bit of the medication to inhibit IL-23 signaling. And when you looked at the dose-ranging phase 2 study for J&J 2113 in moderate to severe plaque psoriasis, we are seeing some of the highest numbers we've ever seen with an oral therapy. 60% of patients getting to a PASI 90 at 16 weeks, about 40% of patients getting to 100% clear at 16 weeks. And right now, the phase 3 dosing is 200 milligrams once a day, whereas in the phase 2 study, it was 100 milligrams twice a day. From a safety standpoint, very, very reassuring what you can expect with an IL-23 inhibitor. Now, being an oral therapy, of course, you want to pay attention more to gastrointestinal and hepatobiliary adverse events, and we're really not seeing any type of signal through 16 weeks. And this is your hot off the press phase 3 data for J&J 2113, which now has the name of icotrokinra. And at 16 weeks, you can see that both co-primary endpoints were met. About 50% of patients getting to a PASI 90, just under two-thirds are getting to a clear or almost clear. And at 24 weeks, we're seeing over 60% of patients are getting to a PASI 90, which is pretty much what we saw in the phase 2 studies. And so a lot to be excited about for our patients with moderate to severe plaque psoriasis. Thank you.